all, I would like to thank Samsung for organizing this very important webinar on a very hot topic in the field of ultrasound. It's a real honor to be moderating, and I would like to also congratulate Dr. Morin. He's one of the experts in contrast-enhanced ultrasound in Quebec. So the two of us will moderate the session. I would like to give you a kind of summary of what you're going to listen to during this webinar. Samsung has invited real experts in the field of contrast-enhanced ultrasound, really pioneers in the field of ultrasound and CUES particularly. The first presentation will be given by Dr. Sidhu, and I will introduce him later. So he will provide you all the important information around contrast-enhanced ultrasound. The second speaker, Dr. Klevert from Germany, will specifically address the interest of CUS in liver in adults. And Dr. De Gennaro from Italy will cover pediatric applications. So we'll cover both adults and children, which is very important because ultrasound is widely available in these two populations. So let's start with the first presentation. It's my real pleasure to introduce Dr. Sidhu. He works at one of the most prestigious academic centers in London, King's College. He's one of the pioneers in ultrasound in Europe. He has been involved in a number of key publications. He has been involved in the guidelines. So he will summarize why contrast-enhanced ultrasound guidelines, advantages of CUS. Dr. Sidhu, the floor is yours. Looking forward to your presentation.
I am Professor Paul Sidhu from King's College Hospital in London, and I'll be looking at using contrast-enhanced ultrasound guidelines in clinical practice. I have been involved in the use of contrast-enhanced ultrasound since the 1990s, and I will try and share some of my experience with you today. Just looking at the background and why we should be using more contrast-enhanced ultrasound, I draw your attention to this publication in the New England Journal of Medicine in 2007, looking at the burden of CT scans on our population. The number of CT scans has proliferated in the United States over the period of time, and in this particular paper in 2007, there was a huge number of CT scans being performed. But of course, 20 years on from then, we are actually doing a far greater number than CT scans. And this is not without its risk. It's estimated that at least 2% of cancers in the United States may be attributable to radiation from CT studies. And it's imperative that we try and reduce the number of unnecessary CT scans and use imaging techniques that are more beneficial to the patient, reducing their morbidity. And this is where contrast-enhanced ultrasound comes in. And the European Federation of Societies in Ultrasound in Medicine and Biology have produced a number of guidelines over a period of time. And I will be taking you through some of these guidelines to show you exactly where they are very important and where you can be using them in your clinical practice. Why use contrast-enhanced ultrasound? Because it has a number of distinct advantages over CT and MR. You can perform it immediately without any preliminary laboratory testing. You can carry it out in a variety of scenarios. You take your machine up to the bedside, to the operating room, into the CT scanner, but it operates in real time. It gives you another dimension to that imaging examination, and you can see rapid changes, and you can capture these rapid changes on your real-time recordings. So what about the safety of contrast-enhanced ultrasound? We know that ultrasound itself is so very safe, but what about adding contrast to ultrasound? Does it actually endanger your patient more than you would anticipate? Well, not really. This is the first paper looking at the adverse events in using SonoView or Lumason, as it is marketed in the United States. And over 23,000 patients were investigated, and there were only adverse events in 29 investigations, or 0.0086%. And these were not serious. There was itching, dizziness, headache, and mild hypertension. And these are rates that are lower than reported for CT and MR imaging using contrast agents. A much larger study came out of China just recently and published in European Radiology, looking at 463,000 patients. And again, the adverse events was very low at 0.034%. Post-administration surveillance by Bracco, the company producing SonoView, shows that there is very little anaphylactoid reactions at 0.014%, and having looked at nearly 2.5 doses that were administered, there were fatalities in 14 patients. All of these were in cardiology and related to stress echo. In fact, it's not sure whether the stress echo or the contrast agents resulted in fatality. So we can see that it's very, very safe in comparison to other contrast agents. But what's the evidence that is of use for you in your clinical practice? Well, let's just look at this example. If you as a radiologist or an imager looked at a CT scan, you would not assess a non-enhanced contrast examination for the liver because you just would not see the lesions that enhance after the administration of contrast. But in effect, your baseline ultrasound examination is always compared to a contrast-enhanced CT examination, whereas you should be comparing your baseline ultrasound examination to the unenhanced CT scan. But just look at the images as you go through in administering contrast here in this patient with a hepatocellular carcinoma. After 13 seconds of injection, you see hyperenhancement of the lesion, indicating that this is a highly vascular lesion, and you're imaging that patient for 5.5 minutes continuously without any danger to the patient, and you're seeing the washout very clearly enough to make an absolute diagnosis of hepatocellular carcinoma in this patient, without recourse to radiation and iodinated contrast material. Well, things are changing in the liver. These are examples of liver lesions seen on routine ultrasound lists in our clinical practice as a referral base from primary care physicians. These are all atypical lesions, indeterminate, but they're all the same diagnosis. All lesions were evaluated with CUS, and they were all hemangiomas. And so this is where you can prevent downstream costs by evaluating and diagnosing patients with hemangiomas, where they are now more often atypical, particularly in the background of a fatty liver. And it's that globular enhancement around the lesion that tells you that this is a hemangioma. What is the evidence that it actually works? Well, this is a review by Richard Barr, which demonstrates that when you compare unenhanced ultrasound to enhanced ultrasound, contrast-enhanced ultrasound, you increase the sensitivity up to about 85% and the specificity to 95%. And when you compare directly a contrast-enhanced ultrasound examination to a contrast-enhanced CT, in the German study, you were looking at comparative sensitivities and comparative specificities between contrast-enhanced ultrasound and CT. So it's very good at diagnosing that focal liver lesion. But of course, with ultrasound, you've got to be able to see that lesion if you're going to target a specific lesion. So hemangiomas, FNHs, and HCCs, metastases are all very sensitive with contrast-enhanced ultrasound. And Richard Barr indicated that the literature supported the widespread use of contrast-enhanced ultrasound for focal liver lesions. In Germany, two major studies conducted about 10 or 15 years ago now looked at whether or not in a multi-center study it was useful to use contrast-enhanced ultrasound for focal liver lesions. And yes, extremely reliable in differentiating benign and malignant lesions. But more important, in the German healthcare system, it was cost-effective. So it was much better to use this agent to prevent downstream costs, because very often these lesions can be adequately characterized with just the ultrasound examination. In the United Kingdom, the NICE guidelines, which is the National Institute for Clinical Excellence, has made recommendations for the use of contrast-enhanced ultrasound for focal liver lesions, and they recommend that if the focal liver lesion is inconclusive on an unenhanced ultrasound scan, contrast-enhanced ultrasound should be administered. It should be administered when you're investigating liver metastases, or if the CT is not acceptable to the person, and also for looking at characterizing focal liver lesions in adults with cirrhosis. And they indicate that contrast-enhanced ultrasound should therefore always be introduced when a focal liver lesion is anticipated on the unenhanced baseline ultrasound examination to be more conclusive of whether that is benign or malignant. So we have enough evidence and bodies of in the United Kingdom indicating that this should be the way you use it. But we are very often the first port of call in ultrasound for a focal liver lesion incidentally seen on an ultrasound examination. How often are these lesions going to be malignant or benign? Well, looking at retrospectively at records in the Newcastle Hospital in the United Kingdom, 21,000 records were examined, 9,000 from general practitioners, where 18.4% of focal liver lesions were inconclusive, and 1,500 focal liver lesions in outpatients found that nearly 30% were inconclusive. So you've got a large proportion of patients needing to be examined with contrast-enhanced ultrasound or other imaging techniques to reach a conclusion on exactly what that focal liver lesion is. How often, if you've got a referral from a primary care physician, are you going to find a malignant lesion? This is very unlikely. So you're doing your patient a service if you're able to tell them there and then that the lesion that we see in their liver is going to be benign. The contrast-enhanced ultrasound will confirm this, and this is seen in about 96% of patients in some studies. So a service to the patient by adding contrast-enhanced ultrasound to the examination. Look at this example here. This is a patient with a very fatty liver with a large lesion in the central aspect of the abdomen. When we practice, we go on to administer contrast when we first see this lesion, and we can see clearly the spoke wheel enhancement, arterial enhancement, and the hyper-enhancing lesion of focal nodular hyperplasia. But often it takes some time to convince your physicians and your clinicians that you don't really need any other imaging modalities for this, but they do go on to CT and MR until you can teach them properly over the years that this is not entirely necessary. So this patient has a benign lesion despite the appearances on B-mode ultrasound. And you can also see that this is useful in other patients with atypical lesions. Injecting contrast, there is infilling of that lesion, and this is a hemangioma. You can also triage the patients using contrast-enhanced ultrasound in the outpatients. These are two different patients with focal liver lesions after chemotherapy. One 49-year-old patient, another 69-year-old patient, where the background liver is fatty. In this patient, it's clearly a hemangioma being unmasked by the fatty liver, but here with washout in the lesion, this is a metastatic lesion. You can triage the patients to the appropriate management based on your contrast-enhanced ultrasound examination. So let's now go on to the EFSM guidelines. The European Federation of Societies in Ultrasound in Medicine and Biology is 50 years old. And it was established in 1972 by 13 European countries and currently has over 30 members societies. They have annual meetings, multiple schools, there are multiple committees and over 20,000 members. You're automatically a member if you're a member of your national society in Europe, and there is individual membership allowed. It's at the forefront of establishing policy of the ultrasound in Europe, and it's a multidisciplinary society, not just physicians and radiologists, but also scientists, engineers, and sonographers. And just recently, the 50th anniversary was celebrated by this editorial in the journal, European Society's journal, European Journal of Ultrasound. Who are members of the European Society? Well, there are many members, and how do you determine who can be a member of the European Society? It's very simple. How do we divide a European for membership? Well, it's based on the UEFA criteria for the Soccer Champions League competition. So if you can enter that competition, you can become a member of the European Society, Federation of Ultrasound in Medicine and Biology. But let's now have a look at why the society is so well respected for guidelines in contrast-enhanced ultrasound. Well, the first set of guidelines was produced in 2004, probably only 5 years after the introduction of contrast in European nations for the use in focal liver lesions. These guidelines were subsequently updated in 2008 and remained predominantly, or were exclusively, liver lesion interpretation. And things got a lot more research and publications demonstrated that there was more widespread use of contrast, not just in focal liver lesions. And it was in 2011 that the society looked at non-hepatic applications. SonoView or Lumason is actually only licensed for 4 specific areas. It's licensed for the heart, it's licensed for the breast, it's licensed for the peripheral vascular system, not the aorta, and it's licensed for focal liver lesions. The breast is used less often now because many other imaging modalities are more informative, and biopsy remains the gold standard. The cardiologists use contrast quite a lot for various aspects of that, looking at the myocardium perfusion, the ventricular outline, and in peripheral vascular system is not so often used anymore, but it is now used much more in looking at endoleaks in aortic stenting. But when a society like EFSAM comes out with guidelines on something that is not licensed, it's justified. And the accompanying editorial at the time indicated that if you were going to use contrast not in non-licensed areas, you were safe to do it from regulatory boards because you knew that you will know based on the guidelines that this is a useful technique and of benefit to the patient. Subsequently, further guidelines were issued by the Society and an update in looking at focal liver lesions in 2012, and continuing on this theme and tapping into the expertise available in the European countries. An update in 2017 on non-hepatic use of the contrast agents was issued. Furthermore, pediatric practice, an EFSAM position statement was issued because there was anticipation of that the FDA in the United States would approve the use of contrast-enhanced ultrasound in focal liver lesions in children. And this remains the only approval for contrast in children throughout the world. Furthermore, an update on the liver was produced in 2020. Pediatric Registry of European Working Group was also published, looking at all the use of pediatric contrast in Europe. And subsequently, a position statement on how to use contrast-enhanced ultrasound for Bosniak cyst catheterization was performed. And the group here strongly believes that contrast-enhanced ultrasound will become the gold standard for the assessment of Bosniak cyst changes serially and at any point in time, with CT being less beneficial. But just recently, the most recent guidelines have been an update in the liver contrast-enhanced ultrasound, and these were simultaneously published in the European Journal of Ultrasound and in Ultrasound in Medicine and Biology. And this sets the standard for assessment of focal liver lesions and is widely accepted throughout the world. This map here shows you the countries in which Lumason or SonoView are registered and licensed, and you can see there are many areas in the world there where there is not access to contrast agents in ultrasound. This is also due to the fact that you need the manufacturer's backup and support for contrast if you're going to be using it in these different countries, and this is not available at the moment. The guidelines had 38 recommendations in total, from safety right down to the artifacts that you see with contrast-enhanced ultrasound. It's a large document, 281 references with 38 authors, but it's all you need to set up your practice in focal liver lesions. And there are charts within the guidelines which actually demonstrate to you the features of various common focal liver lesions: hemangioma, FNH, adenomas, fatty infiltration, cysts, and going through to metastases, HCC, and cholangiocarcinoma. Furthermore, recently, the American College of Radiologists issued their CUS LIRADS guidelines, and this was on the back of the LIRADs that are used working in both MR and CT. And this is a very important publication, but it's important to remember that the recommendation 16 in the contrast-enhanced ultra guidelines looking at focal liver lesions in HCC, with cirrhosis, it's used to establish a diagnosis of malignancy, which is CUS-LRM, or specifically CUS-LR5, but always CT and MR remain required for accurate staging. So if you have a surveillance program looking at focal liver lesions in patients with hepatitis or risk factors for HCC, you're using ultrasound to identify a single lesion and then to classify it. But if it's classified as hepatocellular carcinoma, of course, then you need further imaging and management of that patient. And the classification follows that in MR and CT, with the important classifications being the LR3, LR4, and LR5, LR5 being definitely HCC. But what contrast-enhanced ultrasound can do, and there is a publication in Hepatology looking at a prospective trial on this from Andrei Lishak and his group. Contrast-enhanced ultrasound is able to clearly identify benign lesions and also to be better at teasing out the LR3 to 5, to be able to establish HCC in the more accurately than any other imaging modality. So if you follow this chart, and you got arterial phase hyperenhancement, and this is the key to diagnosing HCC, and if your lesion is greater than 10 millimeters and there is late or mild washout, and you can watch this for 5 minutes, as I showed you earlier, documenting very subtle and late washout, is unequivocally an LR5 lesion. And the multi-center trial showed that everyone was very good at diagnosing an LR5. So you've got a tool here with HCC and cirrhotic livers, with surveillance programs using ultrasound to be able to be fairly accurate or very accurate in diagnosing benign and HCC lesions. So in summary, using the guidelines for contrast-enhanced ultrasound, you're going to be able to manage your practice much better than you would just looking at B-mode ultrasound. So why do you use contrast-enhanced ultrasound? Well, it's dynamic, it's accurate, and you get an immediate answer. And this is beneficial to the patient who's under your ultrasound probe, who knows that you found a lesion and is waiting to hear from you whether that's anything to worry about. If it's from a primary care physician, 90% or over of those focal liver lesions are benign, and you're able to reassure the patient. This stops the need for more expensive downstream imaging, particularly in your socialized healthcare system where cost is paramount. It's patient-friendly. You're talking to the patient, you're interacting with the patient, and it's both safe in both adults and children, with no effects that will be of any worry to you during the examination. However, there is a small possibility of an anaphylactic reaction, and you should always not, this procedure should always not be performed in isolation, but with availability of resuscitation equipment. When? Well, you should do it immediately following the indeterminate focal liver lesion. And if CT or MR image is indeterminate, as we're seeing more and more often, you can then come back to contrast-enhanced ultrasound as a problem-solving tool. And we've seen time and time again, you can pick up those smaller lesions, you can see the washout more clearly to identify that this is a malignant lesion. And how do you do it? Well, follow the EFSON and NICE guidelines. They're all there, all the information is there, and you should be able to manage your practice quite readily, adding contrast-enhanced ultrasound following the guidelines. Thank you very much.
Thank you very much, Dr. Sidhu, for this very nice overview of contrast-enhanced ultrasound. I will start with the first question. Since you have been instrumental in the development of this technique in Europe, what would be your recommendation in terms of practice building? Because we know that, access to this technology is very valuable from one country to another. So even if the contrast is in contrast ultrasound at all, so what are the challenges you see and the solutions you may recommend to the online colleagues wishing to start with the contrast enhanced ultrasound in the future? You're probably muted.
It's always difficult on an ultrasound list that when you have to put a cannula in, it changes your concept. So that's the first thing that's a challenge to everyone. But it is really, when you've injected contrast, you get the diagnosis in 2 or 3 minutes. It speeds up the examination so much. But also you have to look at your practice. Don't start with the hardest things. Don't start with the lesion in the liver that MR and CT and cannot classify. Start off with building your confidence. Look at the focal liver lesion greater than 2 centimeters in the left lobe of the liver, which you can see easily with ultrasound, and then get your diagnosis with the follow-up images. So it's a matter of building confidence over time. So don't make it a big challenge at the start. Make it simple until you're more confident.
Dr. Morin, a question for Professor Sidhu?
I will wait until the end. So we will wait for the assistant or the participant to ask some question. Don't hesitate. I remind them that they can put their question in the Q&A box, and we will be able to ask them to the speakers.
Thank you.
So I have another question. Another question maybe for Dr. Sidhu again. Who do you think we need to convince to increase our contrast-enhanced ultrasound practice? Is it referring hepatologists, medical oncologists? Is it our own colleagues in radiology? Is it our technologists? We're using a lot of technologies to assist us with ultrasound. So where do you see a room for improvement?
It's across everybody. The room for improvement has to come from everyone. The radiologists are as much to blame as anyone else for not making this a common procedure, because it's much easier to sit and report a CT that someone else has done some other time than rather participating physically in doing an ultrasound examination. And we also, as radiologists, don't present the results at meetings because it's always thought that the presentation should be CT or an MR. But the physicians also should be educated, and that's why the hepatology paper from Andre's group was published in hepatology, not radiology. It's to convince the hepatologists that to try looking at HCC, use contrast-enhanced ultrasound, it is the most accurate. So it's a combination of everyone. Usually the technicians and sonographers are very interested in doing this procedure, but it needs support and encouragement from the physicians.
Okay, perfect.
Thank you.
And thank you for comparing the guidelines with the European soccer cup ongoing at the moment. We'll see how France and England are doing.
Okay, thank you.
If there's no question, yeah, we have a question. Bruno, maybe you can...
Yeah, sure. The question from the participant, do you have a dedicated list for CUS, or does your team perform CUS ad hoc as and when they see a lesion during the same scan session?
We have a combination of both. So we have dedicated lists during the week. And in fact, I've just come from my Wednesday list. I had 12 patients on it. I had to run to this webinar. But we have the opportunity for people to refer to that list. But during the week, we do it ad hoc, depending, of course, on the availability of the expertise. But if we do find something that needs a contrast examination, we will do it. So it's a combination.
And maybe one more quick question. How about setting up sonographer-led services?
I would encourage you to do this. The sonographers are very skilled at ultrasound. This is an extension of their practice. But it needs a lot of support and education to achieve confidence in the diagnosis. And also, of course, you're introducing an intravenous injection. But most of the CT technicians are injecting iodinated contrast via things. So it should be just an extension of the practice. And of course, the contrast agents in ultrasound are much safer.
Thank you.
I think it's time to move on. Again, Dr. Estudio, thank you very much for your very nice overview. Let me introduce the next speaker, Dr. Clevert from Munich, Germany, another key opinion leader in Europe in the field of ultrasound. He will cover advanced contrast ultrasound, liver technologies, tips and tricks. Dr. Clevert, the floor is yours. Thank you.
Good afternoon. My name is Professor Clevert, and today I would like to speak about contrast and ultrasound in liver lesion. Liver lesions have a prevalence roughly about 5% in the whole population. Unfortunately, patients with liver mets had at the day of diagnosis a risk of having liver mets round about 25 to 50%. In order to offer the best treatment for our patient, it's essential to know whether the patient suffers from a benign or malignant liver lesion, because this will have major influence on the pathway of treatment. There's a couple of recommendations from the EFSUM, and they recommend that contrast is very safe in adults. It could also be used for pediatric, and it's additional safe. We can also use it for intercavity, and it should be used if MRI or CT have any inconclusive findings. And of course, contrast should be considered as first contrast imaging modality with patients with renal insufficiency. The key question is, can my device do this? Of course, if you look at this old equipment, it's more than 50 years old, probably you will have no success. You need a special software, either it's already on your system or you have to upgrade your system, but without this software, you will have no success, even if you inject a whole bottle of contrast. The recommendation from the EFSUM is also, before we start the examination with contrast, we should do a fundamental ultrasound examination by looking at grayscale and color doppler, and afterwards we should use the contrast setting. So if we look at the shape of the bubble has a size similar like a red blood cell. The first generation was filled with air. Nowadays it's filled with gas. All bubble has got a shell, either the palmitin shell, albumin, or lipid shell, and the major difference in comparison to CT or MR is that we are speaking about a pure blood pool contrast agent. How it's working? You see the single bubble, the wave of the probes compress and decompress the bubble, and the bubble is working as a backscatter. If you have got the proper software, you see the oscillation of a single bubble. If you will try it without this software, this bubble will immediately burst and you have no benefit in diagnostics. Important, patients have to give an informed consent, and these contrast agents have no influence on renal or thyroid function. This means we need no lab, we can go directly and start the examination. The amount depends a little bit on the probe you're using, and round about 1.6 cc of contrast will be fine, and additionally we inject 10 milliliter of saline flash. When we speak about liver lesion, we have to think about 3 phases, and sometimes even 4 phases, but the most time it's only 3 phases. One is the arterial phase. It has got a length between 10 to 15 seconds. The portovenous phase has a length between 30 seconds to 2 minutes. And after 2 minutes, the late phase starts between 2 to 5 minutes. the post-vascular phase, that's only for sinusoid, which is not available in Canada, and so we will not cover this topic here. If we look at these special three phases, we now know exactly what kind of lesion we have seen afterwards. In this talk, I will cover benign and malignant lesion. On the benign side, we have got hemangioma, FNH, adenoma, simple cyst, and abscesses. On the other side, malignant lesion, we have got liver mets, HCC, and CCC. Starting with the benign liver lesion. So, one of the most common benign liver lesions is a hemangioma. In the arterial phase, we have got a perinodular enhancement. The portovenous phase is partial or complete centripetal filled, and in the late phase or venous phase, it's completely or incompletely filled, but typical are these perinodular enhancement. How it's looking in daily work? So we have our bright lesion there. So we inject contrast, we see the perinodules which show up there in the arterial phase. And if we wait, we see more and more growing of this nodule. And in the end of signation, if this lesion has no thrombotic changes inside, it's completely filled, no washout. So we see in the grayscale and color Doppler here our hemangioma. This hemangioma has a diameter around about 3.5 centimeter. We don't see major vascularization. And of course, we probably guess that it's a hemangioma, but we of course have to prove it if it's not known before. So we start with arterial phase. I use the side-by-side mode. On the left side, you have the contrast setting. On the right side, you have the grayscale setting, which is used by a low MI. So we inject contrast. We see very nice this perinodular enhancement. In the center is this lesion and the moment not completely filled. But if we go now to the portovenous phase, so you see it's after 1 minute, it's completely filled, and even in the late phase, also here completely filled, so we know exactly this is a hemangioma. What about this lesion? Is this also a hemangioma? It doesn't look like the typical appearance of a hemangioma. So we have grayscale, we have color Doppler, then we start with the contrast setting, but we see immediately also here a perinodular enhancement. In the middle, this lesion is completely dark. Then we go to the portovenous phase. You see a little bit growing of this perinodular enhancement. And if you go to the late phase, after more than 2 minutes, you see the nodules are growing. This is a giant hemangioma with a diameter around about 10 to 12 centimeters with a lot of thrombotic changes. But the appearance is typical for a giant hemangioma. In the next part, I will cover the FNH. Remember these three phases. In the arterial phase, we have got a strong uptake from the center to the peripheral. In the portovenous phase, it's hyperenhancing, and in the late phase, also hyperenhancing, no washout. So we see our lesion. You see the strong uptake from the center to the peripheral, spoke wheel sign. And then you have also a central scar, but only 60% of all FNH have got a central scar. And you see no washout in the late phase. So we see a lesion there. We see already this lesion has a couple of feeding vessels, strong vessels, much more than the surrounding tissue. And if we start with contrast, you see very nice, strong enhancement from the center to the peripheral, much faster. You also see the central scar already. Then we go to the portovenous phase, hyperenhancing in the portovenous phase. And if we go to the late phase, also here, nearly complete filled. And the black area you have seen in the middle at the beginning of this clip there, this was the central scar. And if the clip starts again, there was the central scar. So typical behavior for an FNH. What about this? This patient has got a site of cirrhotic liver. That patient has got ascites. We see there the lesion. So we look at the color Doppler and power Doppler. We see also here that this lesion have a lot of vascularization inside. So repeat the examination by contrast. Also here a strong uptake. You see it's not only one, it's two lesions. And if we now go later to the portovenous phase and late phase, also here, this is an FNH or then a cirrhotic liver that could be shown up. No washout, important. Adenoma is a little bit difficult, so they have a hyper-enhancing complete. The portovenous phase is either enhancing and also in the late phase. Sometimes it's a bit slighter hyper-enhancing in comparison to the surrounding area, but that doesn't happen every time. So we see adenoma, so we see the uptake from the periphery to the center, strong uptake. And remember that sometimes it could be a little bit darker, but not complete washout. So we see in the fatty liver, there's a couple of lesions, hypergenic lesion. They have also some peripheral vessels, as we've seen it very nice here in this area. Then we go to the contrast. You see contrast takes some seconds, and then you see a strong uptake from the peripheral to the center. You see also a kind of capsula there, that's typical for adenoma. Then we go to the portovenous phase. You still see hyper-enhancing of this lesion, and even in the late phase, no washout. This is portovenous phase, this is late phase, also no washout. So if you have this pattern, this is adenoma, but keep in mind, adenomas are not so often as, for example, FNH. Liver cysts are normally very easy. Remember, we've got a blood pool contrast agent, so they will have no contrast uptake either in the arterial phase, portovenous phase, or late phase. So we see our cystic lesion, and there is no need for liver cysts to do contrast, but sometimes we have got complex cystic lesion, and we see some advantage. So if you inject contrast, you see that this lesion will have no uptake. If you see contrast inside, it is not a hemorrhage cyst, or it's an active bleeding. Is this now a hemorrhage cyst, or is it a solid lesion? So we have two lesions there. One is here and one is there. Probably all agree that probably this will be a liver cyst, but what about this lesion? That is really strange. So we start with contrast, and you see very nice. This lesion is black. This lesion is also black. This is a huge hemorrhage cyst. This is just a normal cyst. And if we go later and look, after 1.5 minutes portovenous phase, no uptake inside. And after 2.5 minutes, even no uptake. So it's a solid normal cyst and a huge hemorrhage cyst. No need for puncture, no need for treatment. Abscess is easy because it's an inflammatory part. So we have got a peri-rim enhancement. There we see this rim enhancement, and inside there is no uptake. So you see there is this peri-peripheral enhancement. There's no central enhancement, and in the portovenous phase and late phase, hyper-enhancing and hypo-enhancing in the peripheral. So we have a lesion there. It looks a little bit suspect, this lesion. This lesion has got a diameter around about 2 centimeters. So we start with color Doppler and power Doppler. We could not see vessels inside, so the question is a hemorrhage cyst or an abscess, or what is this lesion? Of course, we start in this case with a linear probe, so we can also use linear probe. You see a strong rim enhancement. You see a very, very strong, a lot of enhancement. There, it's very, very bright in the peripheral comparison to the surrounding tissue, but no contrast inside. Then we go to the portovenous phase. You still see rim enhancement, and even in the late phase, a little bit hypo enhancement of this rim, but no inside, no contrast uptake. So we know this is a small abscess with a diameter less than 2 centimeters. Of course, treatment will be probably welcome of this abscess. Now we have covered already the benign lesion, so we can focusing on the malignant lesion. And the malignant lesion, we of course start with the liver mets, and we know that liver mets are most common malignant lesion in the liver. So according to the primary tumor, either we have got a very strong uptake in the lesion or moderate uptake, And we have got a hyper-enhancing very fast in the portovenous phase and also hyper-enhancing and non-enhancing in the late phase. So we see there's our liver mets. So we start with contrast. We see strong uptake in this case. And if you wait, you see also nice washout. Once you have seen this washout, you can start to look for a second or third liver mets because this will have got a major influence on treatment. There we see a hypergenic lesion with a diameter around about 2 centimeters. Of course, we ask ourselves, what about vascularization? So we use every time color Doppler and power Doppler. We could not see major vessels inside. There are 2 vessels which are nearly crossing or very adjacent to this lesion. And now we are switching to the contrast setting. So we see this lesion show a moderated uptake, not so strong as we've seen it before. But that's the reason why we also see no major vessels by color Doppler or power Doppler. But you still see this lesion getting darker and darker. Unfortunately, this patient suffered from pancreas cancer. So finally, it was confirmed that this patient had meds from pancreas cancer. What about very tiny lesion? So you see a very, very tiny lesion. This is less than 1 centimeter. So if you ask yourself, where's this lesion? There's a lesion. Even here with color Doppler, we could not see vessels inside. Then we start our examination. There's a lesion in the grayscale. There's a lesion. Also here you see a moderate uptake, only some tiny bubbles intake, so it could not be a hemorrhage cyst. And if you wait longer, you see also this lesion show a washout. And even here, washout, this was also a meds from pancreas cancer, which is very typical because they don't have such a strong uptake in the arterial phase. But you could also see that you could cover tiny lesion with a diameter around about 1 centimeter and even sometimes less. CCC, well, how they behave? They have got a rim enhancement and central enhancement, and in the portovenous phase, they start to wash out like hyper-enhancing, and also in the late phase, hyper-enhancing. So we see typical our CCC, we inject contrast, uptake, moderate uptake, and already in the portovenous phase, we see the washout. Where's the lesion? Take your time, look carefully. Might be a challenge to find this lesion. So we start with contrast. Contrast arrived. You see there's a lesion. Rim enhancement. In the center is a moderate uptake. And now we go to the portovenous phase. You see there's a lesion. Show washout. Washout. Also here, this was a small CCC, but we also see additional, for example, here and here, this patient has also some additional CCC areas in the liver. What about HCC? HCC, we find typically hyper-enhancing, in the portovenous phase is either-enhancing, and in the late phase, often it's hyper or non-enhancing. Sometimes we have to wait a long time, up to 3 or 4 minutes, to see the complete washout. This is typical for an HCC. CCC and liver mets do washout much earlier. So we see our lesion, we see the uptake, strong uptake, and also we see, if we wait for a while, that this lesion show washout. So, when we think about liver, cirrhotic liver, we often guess that the patient maybe has got HCC. That's the reason why we do this screening. But we see there's a lesion, there's a second lesion. We see also some peripheral vessels here, much more in comparison to the normal tissue. Then we start with contrast, and you see both show a strong uptake. Both show a very, very strong uptake. Then we are switching to the portovenous phase. Nothing happening, no washout. Remember, we are after 1.5 minutes. Then we go to the late phase. This is after 2.5 minutes, even not a washout. And if we wait in this case after 5 minutes, now you see it's getting darker. This was an HCC in a cirrhotic liver, so we can say typical behavior. What about this? This is a patient, a young female, I think her age was around about 22. If you see at the normal liver, it's a normal liver, it's not a cirrhotic liver, but this patient suffers from a huge lesion in the middle. There seems to be also some peripheral vessels, but also some central vessels. And if we inject contrast, you see strong uptake of this lesion, much faster in comparison to surrounding tissue. And if we go to the portovenous phases, after 1.5 minutes, this lesion starts to wash out. In the late phase, only the peripheral have enhancement, and the center is wash out. This was a rare case of a fibrolamellar HCC. So keep in mind that sometimes we could even also find HCC in a non-cirrhotic liver. What is the recommendation? So choice is suggested as a first-line imaging technique for characterization in liver lesion. Then it's also recommended if it's an inconclusive finding in CT or MRI. And of course, we also use it as the screening tool. If a lesion is detected as a benign lesion, in contrast, there is no need for operation or puncture because the sensitivity is high. There's a couple of studies which compare the outcome between ultrasound and contrast, and all the studies show that's a significant improvement if you use contrast and quiet for a long time. Also here, if you compare CT in comparison to contrast and ultrasound, all these studies have the same results. There is no significant difference between CT and contrast and ultrasound. In the detection of focal liver lesion, conventional ultrasound has some limitation. In order to improve this limitation, we have to use in contrast. And there was also a couple of studies which show up that if we have this lesion in a good scanning window, the sensitivity and specificity is similar like MRI with liver-specific contrast agent. With my last slide, I would like to thank you. And if you have some time, take your mobile phone. You can scan the QR code and you have a lot of training cases and test yourself. Could you make a correct diagnosis of different lesions? And of course, I also would like to welcome you to our international workshop in October in this year in Munich. Thanks a lot and have a great day.
Thank you very much, Dr. Clevert, for this always clear and dynamic presentation. We will start maybe with one question for the audience. If a sonographer chooses to extend an examination to CUS, would they need to be recognized as a non-medical prescriber?
So in Germany, it's a little bit different because we don't have sonographer. A medical doctor do the examination. So probably I could not answer this question in a proper way, but I guess yes. Because also contrast agent is a drug, and therefore probably a medical doctor have to give them permission that they could inject it.
Okay. And I have a question. Do you have any recommendation on how to store those exams in the PAC system?
Yeah, that's a very good question because sometimes we get a huge amount of data. And my suggestion is, of course, we start with the fundamental grayscale color Doppler. We store clips with a length between 5 to 10 seconds in conventional ultrasound. Then we go to the contrast mode. The arterial phase I will store round about 20 to 25 seconds. Afterwards, I make a break for 30 seconds. I don't move the probe because it's difficult to find this lesion afterwards. I just push the freeze button, wait a half minute, do examination afterwards for 5 to 10 seconds, and push the freeze button again and repeat this as long as contrast is in the liver. So you could compress the volume of data And before you would like to send all these data to the PACS, please make sure that your PACS could receive this data, because we had got the experience, I think it was a Friday afternoon, big PACS vendor, I think it was from Germany, they promised there's no problem. I sent only one examination to the PACS and the PACS completely broke, because the PACS thought every single frame is a single examination. And guess, if you send that 800 frames, they think 800 patients at the same time come to the PACS. I had no friends anymore at this day.
I quite imagine. Dr. Perez, do you have any question?
Yeah, Dr. Kluivert, very nice presentation, summary of the evidence, fantastic images, very convincing. Have a question related to interventions. How do you see the role of contrast-enhanced ultrasound before or at the time of a biopsy, and at the time and after an ablation, microwave or RFA?
So start with ablation. We published our first paper regarding results for contrast and ultrasound for more than 20 years ago. So in 2003, we published our first personal experience with contrast and ultrasound in the follow-up after ablation. And at this time, even if the equipment was not as good as today and the contrast was also a different contrast agent, we could see promising results that we could say whether we have got a successful ablation or not. But the key message you have to transfer is you could not start immediately. It takes some time, because if you have got an ablation, the tissue getting hot, it will boil, it's getting air inside, and you could not look through this air. So it takes probably 10 to 15 minutes. Then you can think whether successful or not. And the major important information is, if you are not successful, you can place the needle, which is right on your table, again, and use the same needle. If you find the information next day by CT that you have got an incomplete ablation, you have to spend another $2,000 to buy a new needle and start from zero.
Very good point. And regarding biopsy, are you using it on occasion to optimize detection of the target lesion?
Yes. Sometimes liver lesion could be difficult to see in conventional grayscale. So sometimes, and it's a hook. In order to improve this hook is, if you inject contrast, you have got a window, 5 minutes. And if it's not long enough, you can repeat it for 10 or 15 minutes, because you could inject a couple times. So you can do the biopsy under ultrasound guided by contrast and ultrasound. That's sometimes a very perfect way. And imagine if you are in the contrast setting and you just push the button that you get some tissue, there will be also some air in this tissue. And this air will be fantastic seen in the contrast setting.
Thank you again for Dr. Kluivert to answer those questions. And we will continue with our next speaker. It's a pleasure and an honor to introduce Dr. Anna Maria De Ganello, who is the consultant pediatric cardiologist with a subspecialty in hepatobiliary and pancreatic imaging and contrast-enhanced ultrasound at the King College Hospital in London. Dr. De Ganello is a reviewer for various international scientific journals, is also an educational supervisor to radiology trainees and member of numerous committees. She also is the author of a quite impressive number of scientific papers and book chapters, many of them concerning CUS. Dr. De Ganello is also a renowned speaker, and she received many prizes for her work and her lectures. So without any further delays, I will leave the screen to Dr. De Ganello for her talk on how to scan liver with CUS, interpret findings, and utilize CUS know-how in the pediatric population.
Hello, everyone. My name is Anna Maria De Ganello. I'm a consultant pediatric radiologist at King's College Hospital in London. And today I will talk to you about the applications of contrast-enhanced ultrasound in the pediatric population, with an emphasis of what is out there as new advanced technologies to help us make the most of this tool. As an overview, what I'm going to concentrate about on the talk is the current state of contrast enhanced ultrasound in pediatrics, and what are the new advanced vascular technologies that allow us a multiparametric assessment of pediatric conditions. And in particular, I will focus on the detection and characterization of focal liver lesions, on the follow-up of liver transplantation. I will touch base on that. Mostly, I will also talk about how helpful is contrast ultrasound in the setting of trauma and in complicated pediatric pneumonias. So at King's, we started looking at contrast enhanced ultrasound in pediatric focal liver lesions, and in 2012 we published this paper looking at our series of patients, and in that series we found that CUS had good concordance with other modalities in terms of cross-sectional imaging, and in particular we showed that it had a very high negative predictive value to exclude malignancy in these children. Moving on from there, there was a general push in the scientific pediatric world to try and establish contrast enhanced ultrasound, and the Journal of Ultrasound published this editorial where we all pushed for more development of CUS in pediatrics, especially considering the excellent safety record of contrast in ultrasound as published in the literature. And the EFSAN came out with a position statement advocating for the use of CUS in pediatrics and suggesting all the possibilities, all the areas where this can be employed in children, advocating the mounting evidence of usefulness of CUS in children, but also calling for more development of the technique. And we were helped in that the 1st of April of 2016, the FDA approved Lumazon, as some of you is known in the States, for characterization in focal liver lesions, both in adults and in pediatric patients. So this particularly opened the door to a more expanded use of CUS in pediatrics, and you can see that by mounting evidence of people performing these as published in the literature. So what is it that we can do with contrast enhanced ultrasound? Well, obviously we can characterize focal liver lesions, and don't forget that another very helpful tool that we have these days is microvascular imaging. And by employing the two together, you can really get the most out of your multiparametric vascular assessment of lesions. So if you look at this video, you can see that with contrast enhanced ultrasound, you can see that the lesion has a central feeding artery with centrifugal filling of the lesion. But if you miss that, or if you're unsure about the architecture of the arteries in this lesion, MVI, as demonstrated here, can really help you define the anatomy of the small arteries within the lesion. And this is an FNH. Similarly, this is a patient with a large lesion identified on ultrasound, which showed the typical stellate pattern of enhancement during the early arterial phase, followed by homogeneous enhancement in the portal venous phase. So you can see how CUS, by identifying this pattern of arterial enhancement, can distinguish between FNH and other conditions such as adenomas. This is a scan performed in a boy who underwent a normal ultrasound, complaining of abdominal pain. But what complicated matters here is that once we found this focal liver lesion, we had to characterize this, bearing in mind that the patient had a past history of medulloblastoma when he was 4 years of age. But as you can see on the video, it was very obvious that this lesion has a central scar with a centrifugal pattern of enhancement and a typical stellate pattern of enhancement, proving that this was an FNH. And in fact, we do see that in the context of a patient previously treated for cancers. This is another example where CUS is indeed very helpful as a problem-solving tool technique. This is a girl who was found to have incidentally this very small liver lesion, and from their original ultrasound scan, she was referred for MRI, but unfortunately, even though the MRI could detect the lesion and show us that there was some shine through, as opposed to proper restricted diffusion, as you can see in malignant lesions, that we were unable to characterize the lesion any further because there was breathing artifact on the post-contrast imaging, and we couldn't define whether there was any washout even after establishing that the lesion was vascular. So this is when you can perform ultrasound, and with the help of the MVI, you can also have a better idea of the lesion you are about to characterize, because by using this tool, you can already see the architecture of the vessels which are perfusing the lesion, and you can have an idea what is happening. Bearing in mind that you need to be aware of the of the effect of breathing and respiratory artifact, which can interfere with your MVI. So you have to try to gain these views with some breath holding. But you can see how that was indeed helpful to perform, because after injecting contrast, yes, you can see at first glimpse that there is a central pattern of enhancement, but you can struggle to confidently call that. But together with the MVI imaging, you can be more confident. You can also do some MIP acquisitions when you look at the filling of this lesion over time. And importantly, you can also these days utilize an embedded software within your scanner, which allows you to post-process the imaging and obtaining time intensity curves. And so by doing this, you can easily compare the pattern of enhancement of your lesion as opposed to the background liver parenchyma. And you can see that the lesion is frankly more arterialized compared to background parenchyma, and then sustaining contrast in the portal venous space. Again, another example where CUS really does help as a problem-solving tool. And this is in this baby. We presented with a focal liver lesion and could not characterize the lesion on MRI because of movement artifact, but after injecting contrast, the lesion showed the typical globular arterial enhancement in the periphery of the lesion, followed by centripetal filling in up until near complete filling in of the lesion, and this was a hemangioma. Similarly, in another baby known antenatally to have scattered multiple focal liver lesions, MRI was unable to fully characterize these lesions, and we performed a CUS. And you can see how very quickly, within a matter of seconds, you can tell that these lesions have a centripetal enhancement from the periphery inwards, and these are multiple hemangiobacteriomas. This is another example of a very small child, 1-year-old boy, who's undergoing regular ultrasound surveillance due to an underlying genetic condition that predisposes him to develop adenomas. Now, how can you prove it? This was the B-mode ultrasound scan demonstrating a vascular lesion in the left side of the liver. And again, these are tricky areas to image with MRI due to its position. But with contrast ultrasound, we can demonstrate that yes, the lesion is arterialized, that it sustains contrast throughout the examination, and this was an adenoma. And you can again draw your time intensity curves looking at this increased arterial enhancement followed by persistent perfusion in the peripheral veins and late phases. Another area where we found that time intensity curves can be helpful is in the cases of focal fatty sparing and infiltration. And despite what is described in the literature as typical features where the lesions is iso-enhancing in all phases, we have actually found that In the case of focal fatty sparing, there is a slower enhancement of these areas as opposed to the background liver. And this was a new feature that we described that we could only be able to analyze by doing the time intensity curves. Again, benign lesions where CUS could be helpful is the case of abscesses, where you may want to identify the main cavity, look for septations, and look for best positions where to perform your drainage. But moving on to malignant lesions, this is an example of a boy with a mass in his liver and a thrombus in the IVC, as you can see here. And following injection of contrast, not only you appreciate the disorganized arterial enhancement of the lesion, but you can see that the tumor has involved with the IVC because it does enhance. So therefore, this is a neoplastic thrombus in the IVC. And in the late phase, just as much as the main lesion is washing out, the thrombus as well is following the same pattern. So moving on to the next topic, what about trauma? The EXAM has produced guidelines to a recommendation for the use of CUS in trauma, in particular in those patients where CUS may not be indicated at the start, where there is a minor injury that you want to see with CUS. It could be helpful to look at cases where there are uncertain CT findings, or most importantly for us, where we use it the most is for follow-up of traumatic injuries. This is an example of a very young boy who was playing with a very dangerous toy, and he got a gunshot wound from this. And you can see on the CT, this is causing very bad state artifact, which is interfering with the interpretation of the imaging. But after injecting contrast, we can follow the hepatic artery easily through the injured parenchyma, looking at its branches and making sure that there aren't any pseudoaneurysms. So we could safely exclude in this patient that there was a further vascular injury of the hepatic artery. And this is to prove that CUS can be helpful to evaluate uncertain CT findings. In follow-up, this is where we find it very helpful. Patients with significant injuries may well develop pseudoaneurysm. This is an example of a boy who developed a pseudoaneurysms following splenic injury. And you can see it very easily on the MRI imaging, and then prove it with your contrast enhanced ultrasound. More and more, we're using MBI as well as adjuvant in these cases, because there are many instances where we do follow up these lesions serially until complete resolution, instead of intervening immediately with embolization. And we've seen that working in parallel with CUS, MBI can also be very helpful in making sure that the vascular lesions that you've identified in the first place, such as the pseudoaneurysms, are indeed resolving over time. And this is again another example where you can easily identify pseudoaneurysms with CUS. And we do use it in terms of our protocol in all patients that are managed conservatively after trauma. We use it also prior to discharge to ensure that patients are safe to be discharged. And by doing this, we avoid repeated CT exposure and repeated radiation, which is of uttermost importance in the pediatric group. This is another example of a trauma where a patient presented with initially, this is a teenager with a shattered kidney. And on the follow-up B-mode ultrasound, you can see how the kidney is expanded and hypoperfused, but there was a suspicion of pseudoaneurysm. Initial contrast enhanced ultrasound did not demonstrate the pseudoaneurysm, but when we repeated it by using MBI first, we could see that this area that we were uncertain about was indeed pulsating. And looking at CUS, it corresponded to a vascular lesion, and we were confident to call this a pseudoaneurysm. So the patient went on to have this embolized, and this was successful. Very briefly on transplantation, this can be followed up also with CUS, especially if you have uncertain findings on your normal Doppler ultrasound that you perform at the bedside. Very quickly at the side of the patient, you can inject contrast and prove whether or not there is vascular patency. So in this case, we could demonstrate partial thrombosis of the portal vein. But again, MBI in these instances is helpful. This is a right lobe transplant with a question over portal vein thrombosis. By utilizing this, you can safely exclude. I'm going to dwell a little bit longer on lung applications of CUS because we find it very helpful in the context of necrotizing pneumonia. This is a child with a complete whiteout on his chest X-ray and ultrasound showing a complex consolidation with parapneumonic effusion. By injecting contrast, we could not only delineate the extent of the empyema, but also the areas of parenchyma that were necrotizing and abscess forming. Similarly, on this case, the B-mode ultrasound performed following the initial whiteout on the X-ray was not particularly helpful at identifying what's necrotizing pneumonia and what is associated empyema. You can see that by injecting contrast, you can easily delineate the two and have an idea of the extent of parenchymal damage through evaluation of the parenchymal perfusion. This is another interesting case of a boy, similar scenario, presented with consolidation, parapneumonic effusion, which was drained as deemed to be an empyema. But following an initial improvement, the child started deteriorating again with, again, a complete whiteout on the chest X-ray. Initial ultrasound scan demonstrates the pleural cavity with complex sedative collection and the pneumonia, and IV injection proved that the empyema component was still significant. But the question was, where is the drain? Is it draining effectively the pleural cavity? And we couldn't answer that, especially in an upset child where you cannot confidently see the tip of the pigtail drain. So we injected contrast down the drain in this instance to demonstrate that indeed the chest drain is in the correct position within the pleural cavity, but instead of draining the whole of the empyema, it's simply draining one single pocket of pus as opposed to the whole parenchyma. So this needed of the whole empyema. And so this needed the injection of the urokinase inside the pleural cavity to allow breaking down of the secretions and more efficient drainage. And this was the check following urokinase, showing that the drain was indeed now draining the whole of the pleural cavity. And so this brings us to briefly touch base on intracavitary use of CUS and how we do it. We use one single drop of sino diluted in a decent amount of saline, 20 to 50 milliliters. This is because you're going into a very small cavity and you don't need to overload with contrast. And you can evaluate easily collection anywhere in the body, really. And by injecting through catheters placed in the chest or in the abdomen, you can look at the position of the catheter, patency of the catheter, volume of the fluid effectively drained, and whether there are any communications or fistulas coming from the drained fluid. So in conclusion with this talk, I wanted to emphasize that CUS and other advanced vascular techniques such as MBI can really obviate the need for cross-sectional imaging. In children, this is more important in the case of trying to avoid CT scan and repeated radiation exposure. And CUS allows not only a qualitative but also a quantitative analysis of contrast intensity over time, looking at wash-in and wash-out information, which will inform us on the nature of the lesion. With the aid of MVI, we are able to visualize smaller vessels, and we can therefore look at capillary perfusion, and it can help us in areas where we could be doubtful with CUS in terms of vascular evaluation, and we could use it side by side. And these techniques are indeed very versatile and can act as a problem-solving tool in very many different scenarios in pediatrics, and can be performed safely at the bedside in the presence of the parents. And I would like to thank you very much for your attention.
Thank you very much, Dr. Radiganello, for this very interesting and well illustrated lecture on the various applications of contrast ultrasound in pediatric population. I encourage the attendants to ask any question if they have, since we're now at the question period. Dr. Radiganello, I have a first question for you. What's the amount of contrast do you use to perform liver ultrasound in pediatric population?
Very good question, because when we first set out to do this, our way of doing it was by extrapolating what we were doing from the adult population, bearing in mind that in Europe, the use of sonoview is still off license, and so there was no indication of overdosage for pediatrics. So we started off literally going by a patient size and weight, comparing it to the adults. And so we're looking at from pre-adolescents all the way to teenagers, more or less, again, looking at their size. They could receive adult dose, but then from then downwards, we would simply halve the dose for smaller children that we would have used for adults. And for babies and infants, we literally use 0.3 milliliters in neonates and moving up to 0.6, up to 1 through the toddler's years. But we simply go by size of the patient, but without really measuring. But in the indications for Lumazan, there are within the description also used by the FDA, there are specific weight-related doses. But in clinical practice, we do it like that, also because going back 0.5 milliliters is still tricky. So that's how we do it. We don't go lower than that.
Thank you. I think we have some question for the audience. Dr. Pelage, you want to ask? Okay, go ahead.
Yeah, very, very nice presentation. I like your chest tube opacification injection. Fascinating. Actually, are you routinely using this technique to check the tubes to avoid X-rays?
Well, not routinely. It's mostly when there is an issue, when there is a question, but there is definitely, if there is a doubt over the position of drainage, of course, for chest drains, they would still all have a chest X-ray just to check for pneumothoraces and things like this, or further pneumonias deteriorating. But in actual fact, if there is a question mark over their position, whether they're effectively draining the pleural cavity, then indeed we use it. And the same goes for drains in any other cavity, any other bit of the body. We use it quite a lot also in transplanted children having undergone percutaneous tubograms and cholangiograms with the biliary drains in situ. If those run into troubles of them not draining, we also inject it down those kind of tubes. So it's really quick and easy and very informative and often therapeutic, because we had a case of a child with a biliary drain and that became blocked, and she developed a fever and cholangitis. And by checking the position of the drain, we realized it was actually blocked, and we helped to drain it, and then the drain started draining quite easily. So there are various different areas where you can use it. You can be very versatile, actually. And when you have an issue, when you're not quite sure with ultrasound, with your standard ultrasound, do ask yourself, could this be answered with contrast, and then use it.
I'm curious, can it be done bedside? You know, if you're dealing with ICU patients, for instance?
Definitely. We do that again for transplant patients, mostly for vessel patency. I've had an interesting case only last week where there was a question mark over our trainees weren't sure about the patency of an hepatic artery. And so we went back together with contrast, and it was like day and night. You couldn't see any arterial flow with an immediate abrupt change of caliber at the portal hepatis, and you knew. So, and our surgeons are very much on board now with this, because and the other advantage in those cases is that, because sometimes the question there is the graft salvageable? How is the graft perfused? And you can also answer that at the same time, looking for any areas of necrosis within the graft, which can sometimes become apparent first on imaging rather than on the biochemistry sometimes. And in fact, this particular patient did not have such a shoot up of AST despite having some ischemic changes. So it's quite sensitive. It's really good.
Thank you. Fascinating.
We have a question from the audience, and it applies to, I guess, the three of us. Has there been any success in using CUS for testicular lesion? It doesn't seem to be a huge amount of literature on it. So anyone?
Dirk, do you want me to answer?
I think because you are the best guy who do this, and I think you have published so much papers, it will be an honor that you start the session.
No, there is literature on the testicular lesion, and the guidelines actually in the EFSM guidelines show where you can use it, but it's very narrow usage of contrast in the testes. If you're looking at evaluating a focal germ cell or a malignancy, then it becomes a little more difficult, but you can tell the difference between a Leydig cell tumor and a germ cell tumor on the time intensity curves, because the Leydig cell tumor, which is a benign tumor, retains the contrast, whereas the germ cell tumors wash it out. But where it's really very good, contrast in the testes, is to show avascular areas. So if you've got a segmental infarction or trauma or an abscess, the contrast will show you that there is no flow in that area. There is infarcted tissue or there's an abscess, and it's a wonderful problem-solving tool. Just today, this afternoon, I did two. One was a trauma, looking to see if the tunica albuginea is intact, and the other one was an infarction from severe epididymolysis, and you could see which parts of the testes were still perfused. So it's a very good use, but narrow usage. Thank you.
Thank you. Do we have one more time, Dr. Palash, for another question? Yes?
Yeah, I have a question for the three of you. I'm curious to know how you organize your ultrasound session. If you are a patient referred to you for chronic liver disease, adult or children for Anna Maria, how do you combine the different modes of ultrasound? How do you use elastography, contrast, fat quantification? What's your typical exam organization in a patient with chronic liver disease?
Maybe Dirk should answer this one.
I think that's a good question. Of course, you can offer the whole solution package. This will include everything. But normally in our daily setting, we only, if a patient comes to us with a cirrhotic liver and we have to look for HCC, we look for stiffness and we look for grayscale and color Doppler, and then we start for contrast if we find a lesion, yes or not. And if we don't find a lesion, often the doctor told us, please do additional contrast, because sometimes you could see in the arterial phase, if you make a fast move, that there's a lesion which shows strong enhancement, which you haven't seen in the grayscale. And sometimes even you find lesions which have got to wash out, and then you know exactly where to start your story and repeat the examination. So of course, fat quantification only take another 5 seconds. Sometimes it's also included with shear wave. So it's up to you which system you're using. Of course, you could offer everything which make you lucky or your patient lucky, but of course you have to think about who pays at the end of the day the invoice.
Thank you.
you.